instruments and start doing what we call the history of present illness regarding that one item. So we teach our trainees that if it seems that there's a demonstration of lack of empathy on behalf of the clinician because you are required to ask these questions the way they are worded, you're required to elicit a yes-no response, and how do you demonstrate empathy and respect when you're trying to move on to the next question, but you still need to get an explanation from the patient about the responses? Is you tell them that that sounds very important, that is very valuable, and I'm going to ask you more about this when I'm done asking these questions. Because you have to remember that these are validated, researched, considered to be reliable instruments only if we use them in the manner they are intended. We have sample dementia screening tools from really short ones like the mini-cog to longer 30-item scales. Regarding mobility, so if you notice here, the definition does not talk about ambulation or walking. When we hear the word mobility, our mind usually goes to walking and ambulation. No, even the movement of a person from one chair to another chair, from the bed to the chair, from the commode, the bedside commode to the bed, all of that is movement. So you have to remember that mobility is not just fixated on people who can walk. So moving safely in order to maintain function and what matters to that older adult. Again, this is connected to the other 4 M's. And yes, there are again multiple resources available to test the ability to use your proximal muscles of the lower extremities to sit up and sit down, to walk, to turn, fall risk, contributors to fall risk. So orthostatic hypotension. STEADI study. This is a site by the Center for Disease Control and Prevention in the United States. It has excellent resources for professionals as well as for patients and caregivers regarding fall prevention, fall screening, fall assessment. If you have an interest in this topic, I would encourage you to explore that site if you haven't done this already. So coming back to age-friendly health system recognition and my appeal to all of you, what is level 1 and what is level 2? So level 1 means you develop a plan, you submit it. If it is successful, you achieve level 1 recognition. You can actually brand yourself, you can advertise, you can promote that we have achieved level 1 age-friendly health system. By the way, there is no cost attached to this. They don't charge you anything to apply and to maintain your recognition. What is level 2? Which is called committed to care excellence. You submit 3 months of data. You do not violate patient confidentiality. All you have to say is, these are the total number of older adults that we took care of in these 3 months, and how many of those for whom we applied all the 4 M's, for how many did we apply 2 M's or 3 M's, and what is our plan to cover 100% of our older adult population in the future. You just give numbers, you do not give patient data. It sounds simple, and it actually is simple. They have worksheets for all healthcare settings. There's a hospital worksheet, there's an outpatient worksheet, and the items in the worksheets typically will be, you have to identify your healthcare system and the parts within that healthcare system. You are going to identify which screening assessment tools you'll use. You'll identify what care plan items you would consider in your menu of options, and who would be the person responsible. And there could be more than one person, more than one profession. And this is My guideline for an implementation process: you start with one of the 4 M's, you identify the tools, you determine the frequency as to how often you would assess or screen, you decide how you will document, where you will document, and how you will share this across settings. So which means if done in the outpatient setting, it should be available, that same information in the hospital setting and back and forth. You will create a care plan, again personalized to that patient. Delineate quality metrics, and quality metrics will not be from an external source. They will be your quality metrics. You will decide what you want to measure the effectiveness of the program. Identify a professional champion. That person is different from the one who carries the primary responsibility. The primary responsibility means the implementation and maintenance. The champion is the one who motivates, encourages, inspires, and promotes the communication about it. So I'm going to leave you with this thought. What are the next steps you will take to implement an age-friendly health system at your healthcare institution or practice setting? And I just want you to think about that. And I'll take questions. Thank you.
Thank you, ma'am, for educating us in such a simple way. And India is aging at a very rapid pace. And we are just aging like Japan. I've already covered in few lectures before also. And this is the need of the hour to implement 4M and to make a geriatric specific elderly safe society. So any questions? If ma'am will, any residents can ask any questions? Any?
I want to remind everyone that this is not just for geriatrics, because geriatrics will already start doing that. This is not just for internal medicine, primary care, family medicine, even medical subspecialties, cardiology, neurology, rheumatology, infectious disease, any one of those. Surgery, surgical specialties, including anesthesia, community medicine. This is intended for all specialties.
I think it's crystal clear. I think there's no any comment from the faculty. So I now expect everybody has understood the 4M, so they will be implementing in their own facilities. So we will try and check now. Any comments from the faculty? Any? Yeah, yes, the question.
Ma'am, thank you for a very interesting lecture, in the sense that we are just beginning to get sensitized towards geriatrics. So all of us will age, and the concept of differential aging for different individuals. But then how do you achieve a common platform? If everyone is going to age differently, how can science kind of have a common platform for the whole process?
So the 4M's framework allows you to have a template that you can use, and then based on that template, when you apply it to an individual patient, you will be able to customize it. So for example, it's like calculating the glomerular filtration rate for an older adult. It's common practice before prescribing, especially for medications that are renally cleared. So if you follow that principle, then you're customizing all your medications that are renally cleared for every older adult. So I'm just giving you one example there. So that is how you end up personalizing it. I hope that makes sense.
Thank you.
Yeah, any more questions? Okay, ma'am, thank you, ma'am, for this elaborate lecture. I request Imogen Gira Singh sir to please present a memento to ma'am.
Yes, so fortunate today. Today we have somebody who is the world authority in geriatrics, coming back to the alma mater after 3.5 decades, and I've been fortunate to share college space with ma'am. And I would request her fellow batchmate and the only W batcher serving Pune complex, Brigadier Kunal Chatterjee, to please come on stage and felicitate ma'am.
Thank you, sir. Thank you, ma'am. Thank you everyone for attending this lecture. Thank you very much.